Good evening, good afternoon, good morning, everyone, wherever you're joining us from. Thanks so much for joining us on this session on vaccines. My name is Bradley Layton from RTI Health Solutions. I'll be moderating the session today with Harry Seifert from GSK. We're very grateful to have you all here today. Obviously, vaccines are a big hot topic. Just brief items of housekeeping. This is in a webinar format, so those of you who are viewing it will not be able to speak or unmute yourself. So if as you have questions that come up during the presentation, please enter those into the chat, and then we moderators will make sure that people get to them during the question and answer session. We'll have 10 minutes for each presentation, and then a 5-minute question and answer session after each presentation. And then presenters, you will have control. You should have control of your slides, and so you'll be able to share your screen and present on your side. So without further ado, we'll go ahead and jump in.
Bradley, we have to warn everybody that this is being recorded for posterity.
Yeah, so, thank you very much.
So please, if you don't wish to be recorded and you're not a presenter, please drop out.
Thanks, yes. So we will go ahead and begin with our first presenter today, Francois Haguenet. Sorry if I mispronounced that. We'll be presenting on evaluation of the potential confounding effect of shingles on the risk of Guillain-Barré syndrome after vaccination with the recombinant zoster vaccine. Francois, so please turn the screen over to you. Please feel free to share your slides.
Yes, thank you. We'll share. Since I cannot share my screen.
Ruben, can we make sure Francois has screen sharing privileges?
Yeah, just 1 second. I'm sorry, who's the individual again?
It's me, Francois Haguenet.
Okay, you should try again now.
Should work. Okay. Hope you can see it now.
Yes, we can. Thank you. Yes.
Okay. Good. So thanks for the introduction. Sorry for this little delay. So first of all, some disclosures. All authors are employed by the GSK group of companies, and this work was funded by GSK. So this work was initiated more than 2 years ago when a statistical signal for Guillain-Barré syndrome after the recombinant zoster vaccine was identified from the vaccine safety detailing rapid cycle analysis and was presented at ACIP. So we thought that the some confounding may generate such an association if the RSV vaccination tends to occur close to an herpes zoster episode, and if GBS may result from a recent herpes zoster episode. So our aim was to explore this in existing real-world data. So the objective was really to measure the association between an herpes zoster episode and the subsequent risk of GBS, and between an herpes zoster episode and the probability of being vaccinated with RZV. This is a slide summarizing the methods. I cannot go in all the details. For the analysis of herpes zoster and GBS, we used a self-control case series design. The data source was the MarketScan US claims databases, and we used the commercial databases for the less than 65 years old and the Medicare supplemental for the more than 65 years old, and we considered them separately in each analysis. The study period was 19 years, starting in 2000. The exposure in this case was the incident herpes zoster, defined as here. And the outcome was the incident GBS episode. The inclusion criteria were subjects more than 50 years old, because that's the age recommendation for the RZV vaccination in the US. The subjects had to have an incident GBS in the study period. And when they had several incident GBS, the last one with an herpes zoster before, within 84 days, was considered. In the analysis, we estimated the relative incidence of GBS between the first 42 days after the herpes zoster episode and the following control period, which is also 42 days long. And then we also ran a self-control temporal scan as a sensitivity for the exposure period. In the analysis of herpes zoster and RZV vaccination, we used the matched case controls analysis, and the matching was 1-to-1. We used the same data source. The study period started on 1st January 2018 because the vaccine was not on the market before. The exposure was the same, so it's the incident herpes zoster. And the outcome was the RZV vaccination as defined here. In the inclusion criteria, it was also subjects more than 15 years old. The cases were subjects vaccinated with RZV. The controls were matched to each case for the gender, the age, and having a visit within the same 14 days calendar period as the vaccination date of the case, which is also the index date to define the exposure. In the analysis, we estimated the odds ratios of presenting an herpes zoster within 42 days before the index date. And in the sensitivity analysis, we considered a shorter exposure period before the vaccination. Now the results for the herpes zoster and GBS first. Here we have the distribution of the GBS cases and the GBS cases preceded by an herpes zoster episode by calendar year. We can see that it's quite heterogeneous in both age groups, and we can see a peak around 2011, 2012 in both age groups. In total, we included 106 GBS cases for the younger age group and 85 GBS cases in the older age group in the self-control case series analysis. Now, the results of the inferential analysis, so the tests for association of herpes zoster and the risk of subsequent GBS. In the younger age group, in the self-controlled case series analysis, we estimated a relative incidence of 2.65 with a lower limit higher than 1, and of course it's significant. In the temporal scan analysis, the identified risk period or exposure period was the same as the predefined exposure period of the self-controlled case series. And the estimate of the relative incidence was 2.42, also significant. In the more than 65 years old, in the K-series analysis, the relative incidence estimated was 1.8 with a lower limit higher than 1. And in the temporal scan analysis, the identified exposure period was a bit longer, and the relative incidence was 2.23, and also we had a p-value of 0.02, which is lower than 5%. So this indicates a quantitative association between herpes zoster and GBS within 42 days for both age groups. Now the results from the herpes zoster and RZV vaccination. First, the distribution of the time interval between RZV and preceding herpes zoster episodes. So what is important to see here is the large number or proportion of subjects with a record for an herpes zoster on the same day as the vaccination date. And we think that's an artifact, as it's simply the indication of the vaccine. So we decided to exclude day 0 from the exposure period in the case control analysis, so in the estimate of the odds ratios. And you can see that the sample size is quite large, as this is only vaccinated subjects preceded by an herpes zoster within 42 days. Now the inferential analysis. So these are graphical representation of the odds ratio estimates for the association between RZV vaccination and a preceding herpes zoster episode. So we can see that the odds ratios switch from lower than 1 to higher than 1 in both age groups when the exposure period increased or was longer, so from 7 days to day 41 to day 1 before vaccination. And so when we saw that, we thought that it would be more informative to split the exposure period between an exposure period from day 14 to day 1 before vaccination and an exposure period between day 41 to day 15 before vaccination. And here are the results. In both age group, we can see that indeed in the exposure period from day 14 to day 1, the odds ratio is lower than 1. And in the period from day 41 to 15, it's higher than 1 and significantly higher than 1. So we saw that this indicates that the probability of RZV vaccination is decreased within 14 days after an herpes zoster episode, but then in the next period, so from day 15 to 42 days, it is increased. So in summary, we found a twofold increased risk of GBS within 42 days after an herpes zoster episode, and we found an increased probability of RZV vaccination within day 15 to 42 after an herpes zoster episode. So in conclusion, this indicates a possible confounding in the evaluation of the risk of GBS following RZV vaccination. We think that studies evaluating a possible association of GBS after RZV vaccination should be designed to address this confounding. And lastly, of course, there were limitations to these exploratory analyses, and it includes the absence of medical confirmation of the events and no consideration of other covariates. Thank you.
Thank you so much, Francois. This paper is open for questions now. Like I said, if you can please type them into the chat, we'll direct them to him. But Francois, while we're waiting, can I just ask, so you have now demonstrated kind of the association on both sides of these confounding triangles, but part of a variable's ability to confound is not just the strength of the association, but also its prevalence in the treatment groups. Do you have any sense of how frequently this occurs, that individuals who have a zoster episode and then are vaccinated, I mean, it's aligning all three and later get GBS, it's aligning all three of those events. Do you have a sense if that's common enough in the studies that have been done to explain the association that's been seen?
Not really. In fact, what I know is that the proportion of vaccinated subject preceded by an herpes zoster episode was not so high. So if I remember well, in the less than 65, it was 850 among almost 250,000 vaccinated subjects. So it's quite low. But it's still a possibility. So indeed, it's a very good question, because I think the prevalence is not very high.
That's certainly something to consider. Appreciate that. So I don't know if you can see the chat, Francois, but a few questions have come in. First, what was the rationale for using the self-controlled case series for the zoster in GBS versus the matched case control for herpes zosters and vaccination?
Yeah. So for the zoster and GBS, it was because GBS is a rare event and it's an efficient design. Also, I know that in the literature, GBS has been evaluated with this design, for example, after influenza vaccination. Now, why I use the matched case control design? I think that indeed I could have used other designs, for example, the case series or the match cohort. But I think the case series is more indicated for rare events. Here, it's not really the case. For the rest, yeah, it was an option, but there is no clear advantage, except of course the efficiency of the case control. As you decrease the amount of data, it's easier to analyze with these large databases.
Wonderful. Thanks so much. There's one more question for you in the chat, but in the interest of time, we're gonna have to move on. So perhaps you can address it in the chat also. Thanks so much, Francois.
Thank you.
We'll now turn to our next speaker, Anna Astropoulos, sorry again for the pronunciation. He'll be presenting on sensitivity analysis of design choices for estimating incidence rates of adverse events of special interest in vaccine safety. Thanks so much.
Thanks a lot. I know it's hard to pronounce the full name of the presentation, so I appreciate that. Yes, I would like to switch gears from a clinical research to more methods research, and I would like to talk about the sensitivity of background rates. So to start with, over the past year, we experienced a massive vaccination campaign, and some of the countries vaccinated more than half of their population. And COVID vaccine potentially saved thousands of lives, but then with the growing number of vaccinations, we also observe a growing number of safety concerns, which requires rapid yet robust vaccine safety studies. In vaccine safety studies, when done in real time, rely on two pieces: the observed rate of adverse events, which reflects the incidence in vaccinated population, and expected or background incidence rate, which reflect the baseline incidence in population. And we make the judgment about safety based on the ratio of these two numbers. So it's important not only to accurately gather the adverse event reports, but also to accurately compute and capture baseline rates. And you may think that this is a trivial task, like it's quite simple. You have a simple equation, you have just 3 pieces, and what can go wrong? But when you start to ask the questions regarding these pieces, it's actually gets more complex. Like, for example, the new cases. How do you define new cases? Or time at risk period? How do you define your start for your time at risk period? How do you define the duration of your time at risk period? Then the population. Do you select everybody in your data source? Do you select a specific subgroup? Do you select patients with the specific features? So all of these moving parts actually result in a high heterogeneity of baseline rates. And if you look at the literature, at a simple example of stroke, you would see that the baseline rates reported in the literature actually differ by up to a factor of 100, which is a lot. And moreover, the baseline rates reported are not only heterogeneous, we also do not really know how all of these moving parts influence the background rates. So this method's work tries to address this gap by systematically examining each component of this equation. So we selected 15 adverse events of special interest from the Brighton list. And for each of the adverse events, we computed incidence rates on 12 data sources from different countries. And for each of the events, we actually tested different approaches and different parameters for all of these parts. Like, for example, for the new cases, we tested 2 different approaches for selecting new cases. For example, using all patient history versus using a given clean window. Then for the time at risk interval, we tested different years, we tested different seasons. We also computed incidence rates for different time at risk durations. We tested incidence rates with including day 0 and without excluding day 0. And we tested this concept, which we haven't seen examined before, which I would like to spend more time on, time at risk anchoring. And then for the population, we tested different age groups, different genders, different races, and then we also selected different subpopulations to compute the incidence rates for these subpopulations. So you can see that there are a lot of small sort of experiments which we conducted on these 12 data sources. And then for each of the experiments, the output was either incidence rate or incidence rate ratio. And for each of the hypotheses, we conducted meta-analysis across all outcomes and across all data sources. And we have a lot of results, but for the purpose of time, we will only focus on 3 main findings. We will start with demographics, then we will continue with anchoring, and we will end up with temporal and seasonal trends. So let's start with the demographics, something that is very familiar to all of you, the influence of age. So given that we started with stroke, we'll continue with stroke. And what you can see here is on x-axis, you see different age groups, and on y-axis, you see incidence rates. And not surprisingly, for non-hemorrhagic stroke, you can observe a clear age pattern with increased incidence in elderly and then smaller incidence in young population, which is well known. But what is striking is the magnitude of the difference. So you can see that incidence rates can vary up to a factor of 1,000, which is a huge number. And this effect is consistent across all databases for common conditions and across all databases for at least common conditions. Then for gender and race, we still observe its influence on incidence rates, but the magnitude is smaller. So now we're switching from incidence rates to incidence rate ratios. And what you can see here is the comparison of incidence rates, from the meta-analysis of incidence rates for males versus incidence rates for females. So whenever the incidence rate is higher than 1, that means that that condition was more common in males. And if it's less than 1, then it's more common in females. And what you can see here is that really there are some conditions that are sensitive to gender, like for example, non-hemorrhagic stroke that we've been discussing. But then there are others who aren't really sensitive. And after all, the magnitude of a difference isn't that large compared to the influence of age. And the same goes for race, is that there is an influence of race for some of the conditions, but again, the influence isn't that large compared to the age. Done with demographics. Now I would like to talk about this concept that we call anchoring. So because in baseline rates, we don't really have a clear point where we start our time at risk. We usually select, and by me I mean researchers, usually select an arbitrary date such as January 1st to start their time at risk window. But what if this is not an appropriate way to start our time at risk? What if, for example, we start our time at risk at the visit, or maybe at a different healthcare encounter? What happens then? So what you can see here is on x-axis, you see different time at risk intervals. And then on y-axis, you see the incidence rate ratio of anchoring on a visit compared to anchoring on January 1st with a visit in the next year. And again, if the lines are above this dotted line, then the incidence rates are higher whenever you anchor on a visit. And if they're lower than this dotted line, then the rates are lower when you anchor on a visit. And what you can see here is that we see a really striking, consistent pattern across all databases and all outcomes, that whenever you anchor on a healthcare encounter, you will always have higher incidence than compared to anchoring on a date. And that is especially important for the short and medium time at risk windows, but also you probably will not be able to see it here, but even for the time at risk windows such as 42 days or 90 days, this effect of anchoring is still present. Then you may ask yourself, okay, but does really time at risk interval matters? So what we observed is that whenever you anchor on a healthcare encounter, for the short time at risk intervals, you'll see much higher incidence than for the other time at risk intervals. But this effect is only present when you anchor in a visit. So if you study a population and you start your time at risk interval on January 1st, then it doesn't really matter if you select 90 days or 42 days or 28 days, the incidence rates will be more or less stable. And then I want to briefly touch on the seasonal trends and temporal trends. And again, there is much more, it's just that we won't be covering that in this session. So a lot of researchers are really concerned about the seasonal trends and the influence of different years. But in fact, what we observed is that the magnitude of the influence of season and year is not that large. So we do observe some seasonal trends for some of the conditions, but not for the others. And then with the temporal trends, we also observe that there is a decrease in incidence in 2020, which is expected, but the magnitude of that difference isn't that prominent compared to the influence of age and anchoring. So to sum up, here are three main findings from this study. Is that the first, age has the largest impact, then gender and race do have some impact, but it's smaller. Then the next most important factor is anchoring. So you want to really think about where you index your time at risk interval, because that would matter a lot and that would influence your incidence rates a lot, regardless of the outcome. And then temporal and seasonal trends have only moderate influence. And you may think like, what do I do with this knowledge? So basically, there are two key implications for your studies that you might want to consider. First is that given demographics matters a lot, you really want to make sure that the population that was used to compute your background rates represents the population where you'll be calculating your rates after vaccination. So you want to make sure that they have the same age, gender, and race distribution. And then when you think about your anchor for the background rates, you also want to think about an event or date that represents your vaccination vest. So you want to really think hard about this point in time, because it will matter a lot. So with that, I'll be happy to take your questions.
Thank you so much, Anna. That's really, really fascinating stuff. Okay, we got a question in the chat. Do you think, they're coming in. Okay, do you think that the impact of anchoring will be different following COVID-19 vaccines, since they are often administered outside of traditional healthcare settings?
This is okay, I'll not try to stop sharing. This is a great question. So we have a separate piece of work, and we asked this question ourselves, like, how do we select this anchoring for different vaccines, and would COVID be different than, for example, influenza? And what we actually found is that, yes, COVID is very different from influenza, because, for example, influenza is usually coupled with a healthcare encounter. So influenza vaccination is given to people who come to hospital or to an outpatient visit, as opposed to COVID vaccine, which actually is administered outside of regular healthcare. So to translate it into very practical things, that basically means that whenever you compute your background rates for COVID vaccine, you would like to use a date as your anchor. And when you compute your background incidence rates for influenza, you would probably like to use a visit as your anchor. And then for the other vaccines, you will just have to try and see what makes more sense.
Thank you. We started a few minutes late, so we're getting a couple extra minutes. Maybe at this last one, you can answer very quickly. So you draw your conclusion on different data sources and healthcare systems. Do the conclusions regarding time at risk hold for each country?
So we have, we have data from Germany, France, Australia, and so on and so forth. And pretty much whenever you anchor on a random date, it doesn't matter regardless of the country. So you'll see the same pattern for claims, EHRs, and for different countries.
Yeah, wonderful, thanks. Take a peek at the chat. There's someone asking if this is written up anywhere, and then again, just a comment about anchoring on a visit biases towards sick people, which you addressed. So thank you so much, Anna. We'll now move on to our next presentation from Anna Cantarutti, who will be discussing effectiveness of influenza vaccination in healthy children, a population-based investigation. So Anna, please feel free to share your slides.
Hi, everybody. Yes. Okay, can you see my screen?
Yes, we can. It's not in presentation mode, but we can see the slides.
Now you can see my presentation?
We can see the slides in edit mode, but not the presentation itself. There we go, yes.
Okay. Good evening, everybody. I'm Anna Cantarutti. I'm a biostatistician from the University of Milano Bicocca. And today I would like to present our study on effectiveness of influenza vaccination in healthy children, a population-based investigation in Italy. Seasonal influenza can cause serious morbidity, mortality, and financial burden. In 2018, among children under 5 years of age globally, there were an estimated 109.5 million influenza virus episodes. More specifically, about 870,000 children aged less than 5 years and about 300,000 children aged less than 1 year are hospitalized each year all over the world because of influenza. And around 10–50% of children need medical care for influenza-related disease. It's estimated that between 28,000 and 100,000 children below 5 years of age die each year due to influenza-related causes, and most of them in developing countries. It seems that the viremic titers in children are higher than in adults, and shedding of virus goes on for longer period. 3–4 children represent a critical source in the transmission of influenza and sustain annual epidemics. In Europe, influenza vaccination is not commonly recommended for healthy children, and vaccination coverage in the pediatric population is very low, which may be potentially due to a lack of data and awareness of the impact of influenza in this age group. Hence, these studies aims to evaluate the effectiveness of the flu vaccination between 2009 and 2019 on a half pediatric population in Italy. We conducted a cohort study for each flu season between 2009 and 2019, involving healthy children from pediatricians enrolled in a PediaNet project. We enrolled all children from 6 months to 14 years of age. Exposed children was identified as those children who received at least one influenza vaccination during one of the influenza season that we consider in the study, defined by National Institute of Health from October to April. The outcome of interest was the diagnosis of influenza or influenza-like illness. The effect of influenza vaccination in each season was evaluated using a Cox proportional hazard regression model, considering the exposure as a time-dependent variable. That means that each children involved in the studies can contribute to unvaccinated as well as vaccinated person time during their follow-up. A propensity score stratification was used to account for key potential confounder, and vaccine effectiveness was calculated as 1 minute hazard ratio per 100. Our results show that the vaccinated children were younger with longer follow-up. They were vaccinated during previous flu season and had more hospitalization, as well as more antibiotic therapies, more pediatric visits, and less flu episodes. We enrolled on average 21,000 children for each flu season, of which on average 8.8% were vaccinated and 9% had a diagnosis of influenza or influenza-like illness. Now I can show you the results regarding to vaccine effectiveness analysis. As we can see, adjusted vaccine effectiveness was always equal to or greater than 50%, except for the flu season 2009-2010 and 2018-2019. The highest value was recorded for the 2060-2070 and 2070-2080 season. We know that flu vaccination change every year, and our results show that vaccine effectiveness observed are almost always in agreement with the effectiveness expected. That depends if the flu vaccine are unmatched or matched with the antigenic distance of the year that we consider. In conclusion, we can say that influenza vaccination proved to be overall very effective in the healthy pediatric population in Italy between 2009 and 2019, suggesting the repetition of influenza vaccination every year. Thank you for your attention.
Thank you so much, Anna. This paper is now open for discussion. Please put your questions in the chat. While we're waiting for them, I'll start with one, and apologies if I missed it. You mentioned at the beginning that influenza vaccination is not routinely recommended for children, but yet there was a sizable number of children that you recognized with it. I mean, but was there any particular, is it widely available? Maybe not recommended, but it's still possible for children to get it, or is there some barrier that healthy children would have to go through to get it? I'm just trying to think kind of the dynamics of why healthy children would get it if it wasn't necessarily recommended for them during that time.
Do you ask me why some healthy children were vaccinated for influenza? And okay. It depends from the mother and from the pediatrician. I mean, there isn't a specific rule in Italy for the healthy children to vaccinated for influenza. So maybe if the children goes to the school or attend some course with other children, maybe the parents are more prone to do the influenza vaccine than the other. But in the last year, all pediatricians recommend also to the healthy children to do the flu vaccination.
Okay, thanks. So there are a couple of questions that have come in the chat. Two very related ones about stratifying by vaccine type, such as a nasal, mist, or intramuscular, or trivalent versus quadrivalent vaccine. So do you see any differences by type of vaccine?
No, we didn't make the stratification for type of vaccine.
Okay.
But it's a good point. For sure, we can consider this stratification, even if it's very difficult to have this kind of data, because in the Pedianet database, that is a pediatric primary care database collecting specific data from computerized clinical files of familial pediatrician. Sometimes we have only the information if the pediatrician make this vaccine, and we for not all children we have the type of vaccine, or if the children made one or two doses of the influenza vaccination. But it's a good point. For sure, I can look at the type of vaccine.
Okay, great. And then two others questions. First, have you used any negative control exposures, such as a non-influenza vaccine, or a negative control outcome to assess residual confounding?
I answer to the first question if we use negative control of exposure. Now, of course, we compare the influenza between vaccinated and unvaccinated children, and we are sure that the unvaccinated children are really unvaccinated, because the negative exposure came from the same pediatrician who recorded the exposed children, and so we are pretty sure that if the doctor didn't report this kind of information, it seems that the children didn't perform this kind of vaccination. For the residual confounding, what was the question?
So I think actually the first question was not so much about misclassification of vaccine exposure status, but just trying to get at residual confounding? Did you use a negative control analysis for either exposure or outcome to test the potential for unmeasured confounding?
Yeah, I understand. I think that our results are not, we don't have misclassification in this kind of data. So I think that these problems are not in our analysis, are not present in our analysis.
Okay, thanks. Maybe we can follow up with that check, because I think there's a little bit more there about the confounding. And then maybe just one last question about reporting the vaccine effectiveness measures with measures of precision. It says hazard ratios usually have a 95% confidence interval. And when reporting vaccine effectiveness, do we need to report a vaccine effectiveness with a 95% confidence interval also?
Of course, we can add the 95% confidence interval of vaccine effectiveness.
Okay. Wonderful. Well, thank you so much for your presentation today. I will now turn the moderating responsibilities over to Harry.
Oh, hello there. So earlier in this session, Anna Stropoulos raised some concerns or cautions about how we did our sensitivity analyses for background rates. And now I guess perhaps a little bit unfairly, Corinne William will present on, in fact, background incidence rates for AESIs for COVID vaccine. So Corinne, please.
Yes, thank you. Thank you, Ari. So I will share my screen. Yes, so here is the disclosure. So the study that I will present has been funded by the European Medicine Agency. Here are the conflict of interest of the co-authors. So in May 2020, the Access project was launched to prepare the European infrastructure to monitor COVID-19 vaccine. It was a very big project, which include several activities with several deliverables, such as template protocols for implementation of observational safety and effectiveness studies, and also background incidence rate. All the material is freely available on the VAC4EU website. So background incidence rate were deemed very extremely useful to contextualize potential safety signal following administration of vaccines. The objective of this study was to first to develop a list of adverse events of special interest, create harmonized event definition, codes, and algorithm. So the list that has been developed has been based on the preliminary list that was developed by the CEPI and the Brighton collaboration. And this preliminary list was further extended and agreed with the EMA advisory group committee. We also update the list over the course of the study because with the rollout of the vaccine, COVID-19 vaccine, we observed very rapidly emerging safety signal, and then we updated this list based on that. So in total, we have included 41 adverse events of special interest, and we have generated background rates for all those events. So this was a retrospective dynamic cohort study using that was run over the year 2017 to 2020, except for two databases for which we use previous years. The study included 10 population-based healthcare databases across Europe. So from 2 databases from Italy, 3 databases from Spain, the Danish registry, claims insurance database from Germany and France, database from Netherlands, and the CPRD from the UK. The estimated source population size was 141.6 million individuals, with the largest contribution from France, Germany, UK, and BFAP, Spanish database that include 8 regions from Spain. So each of the database has its own characteristics, and we observed various provenance of the event, meaning that for some of the database, we could only access hospitalization data, or for some other only the GP, general practitioner data, and for some other database we had a combination of hospitalization and general practitioner data. In terms of the data management and data workflow, so this was a study that was conducted using a distributed data network. We apply a common protocol, which is available on the NCEP register. We apply the conception common data model and a common analytical programs. In this process, we have two phases. The first phase was the syntactic harmonization, in which all the data access provider apply the ETL process, which is the extract, transform, and load, with, as a result, a transformation of the local data into the common data model. As a second phase, we had the semantic harmonization, which was applied to create the study variable. So for this phase, we have developed for each of the events clinical definition form, and we generated list of medical codes using the advanced code mapper tool. We integrated 5 different coding systems. All the access data providers were asked to review and update the proposed medical code based on local habit and prior experience. For each of the ASI, we developed a narrow and a broad definition, narrow and broad algorithm. The broad algorithm is very specific and it has been used in our primary analysis, and the broad algorithm is what's used for sensitivity analysis. We apply several exclusion criteria that are listed here, and we require for each individual to have at least 1 year look-back period. So in terms of analysis, we generated demographic characteristics for each of the database, study population by age, sex, and prevalence of conditions that are identified as risk for developing severe COVID-19 disease. And this list has been based on the CDC website. And then we generate incidence rate by calendar year, by age, by sex, by database, and also in individual with comorbidities. We also provided incidence rate by provenance of the event, for which we had 3 categories: database that only use general practitioner data, databases that only use hospitalization data, and databases for which we had a combination of both hospitalization and general practitioner data. In terms of the results, so we generate study reports, and all the study reports are available on the NCEP website, and all the background incidence rates are also available on the VAC4EU dashboard. We updated the report periodically with refreshed data. All event definition forms for all the ASI are available on the Zenodo platform under the VAC4EU community. So in total, in this study, we have included a bit more than 45 million individuals, contributing to more than 148 million person year. The largest contribution in person time was from BFAP, followed by Pharmo, CDIAP, Danish Registry, FISABIO in Spain, CPRD, ARS, and Pedianet, both Italian database. So in the table below, you can see the demographic characteristic of the study population. So we have distribution by age, distribution by sex, and also the proportion of subjects with at least 1 comorbidity, which vary between 4% from the Pedianet database, which is a database that includes exclusively the pediatric population, up to 28%, which is the Tuscany ARS database, which includes exclusively hospitalization, inpatient, and emergency room visits. Among the comorbidities that we have observed, we see majority of people that has cardiovascular disease that are in blue, or chronic lung disease that are presented in yellow. So I will now go through 3 examples of rates that we have generated. So the forest plot that is on the right side of the slide, this is basically what you can find in the ANSEP, the report that are posted on the ANSEP. For this specific event, for the Guillain-Barré syndrome, we can see that for all of the databases that are included and for all the calendar year, we see that we have very consistent rates varying between 1 to 5 per 100,000 person year. However, if we start to stratify by provenance of event, we can observe that there seems to have an underestimation of the rates if we exclusively use general practitioner database, and we see the rates increasing when we use a combination of database that include GP and hospitalization data. There is also a clear age pattern for this event, increasing with age, with a peak in the 70 to 79 years old. There is a second example, which is myocarditis, pericarditis, where we see that, again, if we stratify according to the provenance of the event, we see that probably an underestimation of this event if we only looked at databases that exclusively include hospitalization data. Rates from GP only database and the combination GP hospitalization are pretty similar. So the forest plots show us that for most of the databases, we have consistent rates while we have identified some outlier, the PediaNet database, but because it's a pediatric population, and here in the Pharmo hospitalization database, we see also lower rates. Again, in terms of age pattern, we see an increase with age, with a peak in the 20-29 years old. And here is a last example. It is arterial or venous thrombosis with thrombocytopenia. If we looked at the forest plot, we see that the rates vary across the different data sources, and this is really reflected by the stratified analysis according to the provenance of the event. If we only look at databases that include general practitioner data only, we see really a small incidence rate, which is probably underestimated. And we have higher rates when we start to have databases which provide more complete data setting. Also, if we look at the pattern in age, we see a pattern in the age increasing with age for this event. So in conclusion, this study demonstrates the strength of the infrastructure to generate background incidence rate using a distributed data network across Europe. It allows us to generate rapidly rates for newly identified adverse events of special interest, such as thrombosis with thrombocytopenia. We had a pre-agreement with some of the DAP to facilitate the governance approval process. However, in some instances, we faced challenges to access the data in a timely manner. It was the case for the French database, for which we just received approval to access the data. And for the Danish registry, the process to get access to data is quite long, and the DAP prefer to use a data set that was previously approved. The study highlighted the heterogeneity across the databases and of course, in the type of medical records, including the provenance of the event. For this reason, we did not provide a pooling across all databases. And finally, the study generated background rates that are representative to the European population and that are used for assessment of safety of COVID-19 vaccine. Thank you.
Thank you. We'll open the chat now for any questions.
So I'm looking at the question.
Would you like me to read it? Would you like to read it and then respond?
Yeah, I can start. So 2020
Okay.
is a special year. So yes. So so that's true that in our assessment, so So in the forest plot, you see the data that are stratified according to calendar year. And that's true that for majority of the event, we observe or a decrease or an increase in rates in 2020. In the data I presented, stratified according to the provenance of the event, 2020 was not included in this evaluation. Okay. So I see another question that if the rates compared to same rates identified using the same data. So we have a full report available on the NCEP, and for each of the events, we try to put in context what we have generated, looking at the data published, including the recent paper from the Odishi group and also the paper from Guberno from CDC, and also other studies. So overall, it was fairly comparable and fairly aligned with published reference. So regarding the availability of data by provenance of the event, so yes, just for you to know that we are in the process to develop the manuscript, and this will be emphasized in this publication. So yes, this will be available. Yes, there is a question about completeness of vaccination exposures that I cannot address because it was not included in this study. We did not look at vaccination. So there is a question about how can we use these background rates for other continents like Africa. So that's a good question. I think this is really a question about epidemiology. So the question is really, is the epidemiology of a specific event differ across regions, yes or not? I think it could be applicable if we don't have better evidence. I think you can use what is publicly available. And yes, I would say that if you don't have better information for Africa, you could use those rates. Yeah, I see a lot of questions actually. So does the requirement of a 365 days record introduce any bias? So we did not test for this. So we just applied this criteria as a strict exclusion criteria. So there is a question about emergency care, where they are included. So we had, in our study, we had two databases, which include emergency home visit. It was the ARS from Tuscany and the FISABIO from Spain. And those two databases were included in the third category, so GP and hospitalization data.
Great, thank you very much.
Yeah. Should I stop here?
Yes, yes, I think you can catch a break and
Okay,
answer the other questions offline.
Thank you.
Thank you. And thanks to all the folks posting questions. So our final presenter and of course, my screensaver went on. Our final presenter for this session, whose name, forgive me, I don't recall, is presenting. Thank you. I'm trying to do this from memory because my screensaver obliterated the email with all the useful information. I do recall that you're presenting a case control study in a French database.
Yes, with MS. Thank you very much. It's Lamia Grimaldi.
Oh, thank you so much.
Can you see my screen?
Yes, we can. Please set your PowerPoint to presentation mode.
Yeah. Okay, I think it's okay now.
It is.
So thank you very much. So I'm going to present vaccination and acute flares in multiple sclerosis, which is a nationwide case crossover study using the French SNBS healthcare databases. So here are my disclosures. No personal or financial relationships relevant to this presentation. So while several studies investigated whether vaccination is associated with the increased incidence of MS, very few of them have focused on whether they may trigger flare-ups in patients with MS. Vaccination may potentially induce an immune attack on the myelin sheath, which would lead to a flare-up. So our objective was to assess the association between vaccination and the risk of acute flares in patients diagnosed with MS, and also to compare vaccine types, bacterial versus viral. So we performed a case crossover study where cases were MS patients who experienced at least one flare-up, and the time windows were of 60 days duration for the, of course, excess risk time window and for the control time windows. And we selected up to 4 control time windows for each case. So our data source was the SNDS database. The SNDS database is a nationwide healthcare insurance system databases, which cover 97% of the French population. It records the data on all covered medications, medical consultations, biological tests, procedures, and all hospital visits, the public or private hospital visits. Our target population was patients diagnosed with MS, incident or prevalent MS, and our study population was all adults identified in SNDS database over the period from 2007 to 2017, 11 years, using a combination of specific MS criteria, the MS code for chronic disease coverage, which is a specific chronic disease code coverage in this database, and or hospitalization with MS-related diagnosis using ICD-10 codes, and or specific treatment using ATC codes of specific treatment of MS. So we had a total of a bit more than 105,000 eligible patients. Our outcome was acute MS flares identified by hospitalization or outpatient visit. Hospitalization for MS flare was defined as any hospitalization with MS-related primary discharge diagnosis using ICD-10 codes, and the outpatient visit for MS flare was defined as either an outpatient visit to a neurologist or ophthalmologist, followed, well, both criteria were considered. So outpatient visit to a neurologist or ophthalmologist, and followed within the 7 days by a pharmacy dispensing of a high-dose oral or IV corticosteroid. And the flare was eligible if preceded by 4 months without another flare. Exposure was vaccines that defined by dispensing of a vaccine in hospital or community pharmacy. Vaccines were classified according to their ATC classification, the second level for the vaccine group, third level for bacterial to distinguish between bacterial, viral associations and other vaccines, and the fourth level for disease targeted by the vaccine. The vaccination exposure itself was assumed to occur 1 day after dispensation. The odds ratios were obtained using a multivariate logistic regression analysis estimated by a generalized estimated equation, a GEE model, with cluster-specific effect for the patient level and for the flare level. covariates considered in the model were the number of hospital admissions unrelated to MS and number of visits to physicians within each time window to control, specifically to control for epidemics related vaccinations. We also stratify by type of flare, so incident and non-incident, type of vaccine, age groups, gender, time since diagnosis, and patients with more than 6 flares during follow-up. However, for this presentation and for the sake of time, we choose to present results on type of flare, type of vaccination. We ended up with a population of more than 105,000 patients with flares during the study period considered for the study, a majority of females, and the mean age, with a mean age of 41.6 years. The total number of flares was 117,000, more than 117,000 flares, with 2 flares, a mean of 2 flares per patient. The delay between flares was, the mean was 3.3, and we ended up with 8% of the flares with the one control time window, 6.3% with 2 control time windows, 5.5% with 3 control time windows, and the big majority, more than 80%, with 4 control time windows. The total number of flares was divided by, distributed on 26% of the first flare of an incident patient, more than 30,000 flares, and 74% of patients with non-incident flares. For the vaccine exposure, 53.8% of patients had at least 1 vaccination during the study period, with a 12.2% for antibacterial vaccine and 23.1% for a viral vaccine, with the majority of pneumococcus for the bacterial, antibacterial ones, and flu vaccination for the viral vaccines. So here are the results for non-incident flares. The distribution of adjusted odds ratio for these non-incident flares, that goes from 0.83 to 1.6 non-significant, but we can see that they are all around unity, with no association observed for all vaccination, and a statistically significant association with the occurrence of non-incident flares with antibacterial vaccine, that is still low, but it's statistically significant, carried by the pneumococcus vaccination, with 1.33, going from 1.12 to 1.6. For all the rest, no statistical significant association. Now for incident flares, the results are close to the others, but no statistical significance is observed here. They are all around unity, going from 0.93 to 1.71, but with no significant association. The main advantage of this study is that it's a large population-based study as compared with the previous studies that included a few hundred cases at best, which lead our studies' generalizability and statistical power were much higher to allow for hypothesis testing. The principal limitations are notably due to the administrative nature of our data source, with uncertainty in the definition of non-hospitalized flares, because they are not coded with a specific code. The inaccuracy of time windows of exposure and of timing of flare occurrence that could make biased results towards the null, and a residual confounding by indication that cannot be excluded if seasonal occurrence of both flares and vaccination occur. Our conclusion is that no association was observed between any vaccination and MS flare-ups. However, a potential association between antibacterial vaccines, especially pneumococcus vaccine, and MS flare-ups was observed, and calls for individual benefit risk assessment, and no association was observed with antiviral vaccination. Thank you.
Well, thank you. We'll open the chat for questions, and in fact, we already have a couple. So the first question is, can you explain, oh, I'm sorry. The first question is, can you imagine other types of flares or aggravations for which a GE model and these databases could be used?
For this database for other flare-ups other than MS? Sorry,
I assume that's what they mean.
Oh, of course. In fact, it's a huge database where you have all the French population. The problem with the problem with the database is for all the outpatient events, we don't have diagnosis. So we need to define, approximate any diagnosis by drugs and specialized doctor's visits. But if in your subject you can focus on events that are automatically hospitalized, you can use it for any flare-ups, any you want to study.
Thank you. The next question. Sorry, it's hard to follow the questions, but it says, case crossover is biased by temporal trends and exposures, hence is not usually used for vaccines, and SCCS is a more natural choice. Self-controlled case series.
Yeah, yes.
So,
well,
I think that's more a comment than a question.
Yeah, well, we chose case crossover, maybe. Well, I can say we thought a lot. We used, I think we had a problem because of the flare-ups, but in fact it was natural. We started using this crossover, and we did not really, in fact, we did not really think a lot of using another model, to be honest.
Yes, so I will comment that certainly for this situation of immune-mediated diseases, there's a large amount of heterogeneity between patients. And so very often it's more helpful to at least look within a patient, if you will, as well as between patients. So I would consider that to be especially important for immune-mediated diseases such as this, just from a clinical standpoint. And I think MS is its own particular challenge because of changes in the disease course over time for the majority of patients.
In fact, it was this because we had 11 years study period, and it was difficult to use the self-controlled case series design because of this huge duration.
Yes, thank you.
Absolutely. Thank you.
Okay. Well, not seeing any additional questions, I'd like to thank all the presenters for their hard work and their wonderful presentations. I'd like to thank the audience for being so engaged. And of course, I'd like to thank my co-moderator, Bradley, for being a great guy to work with. So the recording for this will be available for you to review at your leisure. Thanks very much, everybody, and have a great day.
Thank
Thank you all.
Thank you very much. Bye-bye.